Okay, thank you very much again to Gian and Dr. Jitendra for enabling this course to happen. We're moving into very much the application of biomechanics to injury prevention today. This is lecture 13 and 14 out of the series, looking at bones, injury, and prevention. And we're going to start off by looking at the synovial joint, failure of the synovial joint, and then how we go and repair it. And we spent a lot of time already discussing the limitations of the synovial joint in its current form. The healthy joint lasts up to 70 years. We recognize that the best man-made replacement at this stage lasts somewhere between 15 as an absolute upper limit, 20 years. So it's probably worth having a quick recap as to why this field is so important for those who haven't seen slides from the earlier sessions. So synovial joints are a very complex engineering structure that require the interface of two highly specialized surfaces. Here we have a smooth articulating surface of the femoral head, so that's the very top of the femur, and that sits inside the acetabulum cup of the pelvis, and that forms our hip joint. That is bathed in synovial fluid, has a ligament to hold the hip joint in place, has various ligaments that surround the outside, a synovium to create an airtight, watertight seal, and this will last for a number of years, until a point where the joint may be influenced negatively by disease. For example, we can see a distinct difference between a diseased cartilage surface and a healthy one. This is a relatively pain-free surface, and so healthy people don't appreciate perhaps the significance of their synovial joints until you get to a stage such as this. This is a very painful condition, and people suddenly appreciate what they don't have as opposed to what they do. Rheumatoid arthritis is slightly different. It's a significant and substantial deformation of the fingers in this case, and that's a consequence of joint degradation, where the tendons and ligaments, the loads that they apply are in effect forcing and contorting the phalanges of the hand into an impractical and unusual shape. So we aspire to achieve this and retain this. In reality, for a number of conditions, we can lead to having a dysfunctional synovial joint. The job of engineers is to try and find a way of replacing this to best approximate this. And this has been happening since the 20s and 30s, where maverick surgeons were trying to come up with novel solutions. In the 50s, 60s, and 70s, this field really accelerated. Despite their good work and good efforts, we can manufacture synthetic replacements that last 20 years or thereabouts, but the problem is that our population is able to grow older as a consequence of other medical technologies, and our lifestyle means that it becomes sooner that we need these implants. And so whereas 20 years used to be long enough, in reality we're having implants sooner, we're living longer, and so 20 years doesn't span an entire lifespan. When we replace a dysfunctional component such as this, we've discussed already how it's important to ensure that the new implant is very well integrated into the bone. This is because we're dealing with very small tolerances and very small differences in dimensions, and so we need to ensure that any replacement components are integrated entirely into the surrounding tissues. An aim of orthopedic biomechanics is to achieve that solid and strong interaction, but to a certain extent that's at a detriment to the need to replace these worn-out replacement joints 15, 20 years down the line, because where you have such good osteointegration, where the bone and the implant are integrated very strongly to one another. The surgeon's job is then to try and remove that implant and to replace it with another one in potentially an old and frail, yet still needy patient, worthy patient. And so there is a drive to increase the length of time that these existing implants last to avoid quite vulnerable patients going through traumatic surgery of having to pull out one implant and put in another. Very quickly touching again on osteoarthritis. Here we see our specialized cartilage surfaces, our subchondral bone, and our very small volume of synovial fluid that sits within the capsule. In actual fact, not only do we have the tibiofemoral joint, but we've also got the patellofemoral joint as well in the knee. But this is the one that is the main focus of implant replacement. And the common example is that this component, the femoral condyles, are replaced by a metallic component, ideally unicompartmental. That means one side of the two condyles are replaced in the first instance to effectively buy some more time, to delay the need for a full knee replacement where a metal tibial plate is put in with a plastic bearing surface on the top. The metallic components, typically the cobalt chrome or stainless steel, and the plastic component is ordinarily high-density polyethylene that's being cross-linked. And we can see the problem that this is causing. It's a huge issue in the West, and I gather from speaking to colleagues that it's an emerging problem in the East. An emerging problem that's likely to grow and grow as diabetes and obesity become more of a problem. Currently, over 60, we have nearly 20%. 1 in 5 females are affected by osteoarthritis, 1 in 10 males. If we factor in obesity, if we factor in some of the population being more active, then that's likely only to increase. There have been very few interventions that have been scientifically proven to actually improve the synovial joint longevity. There have been many that have been proven to accelerate its degeneration. We can try exercises to improve synovial joint health. Decreasing joint stress can be achieved by reducing weight or by resting or even walking with a cane or a stick. We're always trying to get to a stage where there is less stress going through the joint. About 50,000 knees, 50,000 hips are replaced in the UK alone every year. We've got a population of 960 million. We're treating 100,000 of those every year with a new knee or a new hip. And so it's significant and substantial. Typically, joints last 10 to 15 years. We're talking, when we say 20 years, of a very upper limit. And so we need to be cognizant of the fact that if you have a replacement at 65, it's going to last you potentially till you're 80. A substantial number of people in the UK are still alive when they're 80, and they run into the risk of their artificial joint needing replacing again. And that becomes very demanding an operation to both perform and to withstand as a patient. So here we see some examples of hips and knees. This is a unicompartmental knee. So we have a white articular cartilage surface. And in cases where there is a focal defect, or where in this instance on the lateral condyle, because here's our fibula, then rather than cutting away the knee and replacing the entirety, the surgeon would opt here to replace just one element of the knee. And they've replaced also the tibial component with a unicompartmental knee as well. There are debates in knee replacement as to whether there is benefit for this tray to rotate, such that you get more realistic range of motion from the knee. Also, should the cruciate ligaments be retained or not when it comes to the design? And we've spoken previously about how we can use motion analysis to have dots, balls, stuck on the outside of the skin. And we ask patients who perhaps have had a rotating bearing to perform certain activities in a motion analysis lab, walking, stair climbing. And we're able to measure their range of motion post-operatively when they're back to full fitness. And then we can compare that with the group who have a fixed bearing knee. And we can see how comparable their motion is versus what we expect a healthy knee to be doing. And it's these kind of studies that have great value because a joint simulator, which the wear properties and the wear characteristics of these designs are tested and characterized, only provides so much detail and so much information. This is the superior solution in terms of creating a device that can be easily replaced with a full knee replacement, but we need to be sure that the quality of life that this is aiming to achieve is actually realized by the patient. Here we have a full knee replacement. Again, the metallic bearing surface on the femoral condyle, the plastic bearing surface on the tibial plateau, and it sits on a rigid metallic tray. Whether the plastic component on the tibial side is able to rotate on the tray or not is a topic of concern. It enables more accurate motion, but where you have relative movement of one component to another, you run the risk of generating wear. There will inevitably be wear. The question is how much wear and how many wear particles does that movement generate? And is that advantageous versus the greater comparability of the movement that those types of knee get versus a real knee? Or do you generate so much wear that it's actually negative and detrimental to have that feature? Here we see again, these are, in essence, foam bones, so anatomically correct. But the mechanical properties are inaccurate. And you can see that it's quite an invasive procedure to get these implants in. If you were to do a total knee, you would extend that cut across the entire width of the tibial plateau. And so once you've taken that cut and your stem goes into the tibia, and this is cemented down, you can imagine how it's actually really quite challenging to pull that back out again and replace it with a second knee replacement. Here we have a full replacement. Again, we can see the ligaments in place on this model. Our tibial polyethylene component has significant thickness. The thickness within it is actually a lot thinner because the femoral condyles move into the tray itself. And another example here of a unicondyle replacement just on the medial side. Hips have a greater number of materials that are used in their replacements. So here we see a metallic stem that extends beyond the length of this schematic. The femoral neck is one component alongside the stem. But here we have compartmental replacements. And that is that the ball here is a ceramic material. And the ceramic fits onto the head. And this has advantages because if there is failure of the head, then you can leave the stem in and you can effectively replace the ball. But there is risk of having movement again because you've got two interfaces, or one interface between two materials, so that you could generate wear particles between the ceramic and the metal. If you were to generate wear particles, then those wear particles would be very hard because they're either from ceramic or metal, and so the risk of those wear particles creating further damage and further wear is greater than where you have wear particles from here. These wear particles from the polyethylene only will be relatively soft. If you have wear particles from a ceramic and metal interface, then you're going to have hard particles that very quickly accelerate further wear. Here we've got a metallic head, probably fixed onto the shaft, so it's one component. And this fits then within a metal cup with a plastic liner. So the metal cup has a couple of holes at the top, so that's screwed into the pelvis, meaning that the plastic liner is a push fit, so it snaps into the metal cup, and so it's a smooth inner surface. And the key to all this is to try and generate materials that are as smooth as possible to ensure that when we talk about our friction and we aspire to get the best possible lubrication system, we give the body as much chance as possible to get to the right side of our Strybek curve to hydrodynamic lubrication by having surfaces that are as smooth as possible. And so metal is common because it's hard and it's relatively easy to get a high quality surface finish. As we touched on previously, there have been designs where the liner isn't used at all, so it's been metal on metal. That is a metal cup and a metal head, which theoretically provides a perfect solution because you can get a very smooth surface on both sides, and so the likelihood of generating advantageous lubrication is really quite good. One of the problems is that whilst you can get this relatively smooth, you need to generate higher velocities, thinking back to our Strybek curve, you need to generate higher velocities to generate better lubrication properties. And so it's good here to have a larger head as possible. Why? Because when the leg moves through any range of motion, the bigger the head is, the faster that radius or that perimeter will travel. And so a large metallic radius is good because it enables us to have faster sliding velocity, and so increasing our chance of getting to hydrodynamic lubrication. So we had large heads fitting into a large metallic cup. But the downside of having a large head is that it slides further. And so where you have a greater sliding distance, then intuitively you're going to have a greater risk of wear because it's going further. And indeed, the failure of metal-on-metal implants wasn't really their rate of wear. Patients weren't complaining overly about these implants failing prematurely. It was the consequence of the wear particles they generated. And they were trapped around the soft tissue. The synovial membrane around the joint trapped those metallic ions, and they became known to be harmful to the body. So metal on metal, from a tribological point of view, seemed to be a success. You had your big head to give you the fastest possible velocity on the outside, which meant that you were more likely to reach these more preferential regimes of lubrication. The downside that the joint simulators couldn't tell you is that the wear particles that were produced were held in the synovium and that they were actually very harmful and dangerous to the body. This head here is a pink head. That's a ceramic head. Ceramics can be even smoother than metal. And so ceramics offer the opportunity to have smaller heads. And so you can have a smaller head because you don't need to generate the speed of, you don't need to focus as much on generating the speed to achieve preferential lubrication. The risk of having a small ceramic head is a risk of brittle fracture, insofar as ceramics, much like the ceramics that we use in everyday life, are prone to failure. Another solution is resurfacing. We touched on this earlier in the week too. So resurfacing is an equivalent to unicondylar replacement. That is that you try and preserve all elements of the natural joint for as long as you possibly can. So this is effectively a cup that fits over the femoral head and is attached to the existing head by a screw. So you would cover the femoral head and you would replace the acetabulum cup at the same time. And we can do this on both sides. There's no reason why that can't happen bilaterally. And here we see one of the dilemmas. How do you get your femoral head to be as secure as possible? This implant here was probably cemented in place. And so you would resect the femoral head at the femoral neck. You would expose the canal, the hollow tube within the bone. You would put a plug at the bottom to stop your cement from falling out the base. And then you would push PMMA, polymethyl methacrylate bone cement, into the cavity that you've created. You would then hammer in this stem such that you would get the bone cement being squeezed up surrounding the side of the femoral stem. And that goes off very quickly. That sets very fast. And so your head is secured in place pretty quickly. You can, though, get breakdown of the PMMA cement. You can be at risk of not getting a uniform thickness of PMMA either side of the implant. And so much like any kind of DIY where you were trying to insert something blind into a cavity, you're reliant very much on the technique of the surgeon. You're very much reliant on the technique of the tradesman, were you to have a similar thing done outside of an operating theatre. And so there is risk of the PMMA cement-based route that the fracture doesn't set well or that the femoral stem doesn't set in the correct alignment. And it doesn't take much to realize that this is a very close, snug fit. If the femoral stem is in any way out of line, then you're going to get an increased stress, perhaps on the rim of the cup itself. Increased stress will relate to increased wear and premature failure of your implant. This bone here is a coating. That hydroxyapatite coating is encouraging bone ingrowth. And so here, we want the bone to grow onto the stem. And so that's probably going to be a cementless design. So there wouldn't be any cement. This would be layered with cement as you hammer that into the femoral shaft, whereas this particular design here wouldn't be. We also get some designs with a collar, such that it resists excessive intrusion of the stem into the femoral shaft. And that's the other main design choice that the engineers have. Do we have a collar that limits that movement, or do we have a collarless design? And so this touches on the engineering aspects of tribology, again, of artificial joints. It's predicted that per million cycles of a metallic versus polyethylene component, you get about 80 millimeters cubed of wear debris. That's from a femoral head, so a metallic head that's 32 million in diameter. However, if you reduce the head size, it's possible that you can reduce the wear. But this is very much dependent on the precision of fit and the use of the implant by the patient. And so these are only indicative numbers. Tribologically, we would go for a large head because that increases the velocity, but at risk of increasing wear because it slides further. But wear particles are only, or wear studies rather, are only indicative to a point because of the limitations. But ultimately, the risk is, or the ultimate aim is to avoid the generation of wear particles at all, because as soon as you get wear particles generating, then it effectively acts as grit within your lubricant, and so it accelerates further injury. And there are a couple of links to stories about metal-on-metal implants. And that is that engineers understand and recognize the importance of having biocompatible materials. But there's also a need to be aware of the consequence of those materials becoming ingrained in systems that weren't originally intended. And so the metal-on-metal ions, so that the metallic ions from the metal-on-metal implants ended up in the lymphatic system. And at that point, they were seen to be causing significant problems. These pictures aren't brilliantly clear, but effectively what we're seeing here is 1, 2, 3, 4, 5 different wear stations. And so there's a femoral head within these stations, and the machine is trying to systematically replicate what's happening in the human body. Indeed, a similar example down here, trying to replicate what's happening so you can get some kind of measure of friction. But it all harks back to this. This is what we're desperately trying to achieve. We're trying to get replacement joints that drive into this superior lubrication regime, where we have our two surfaces that are physically separated by our layer of synovial fluid. We know that the natural joint sits here somewhere, though the minimal wear that takes place indicates the regime must be something similar to this, at least through part of the gait cycle. And it's up to us to try as best we can to replicate that in the synovial joint. And this is what we want to be cautious of. We know that friction equals, the frictional force equals μr. That frictional force is a combination of the adhesive and the deformative friction. So we have two concepts that are resisting the sliding of one material over another. And if we can minimize the effect of both of these, then we minimize the friction, and so we have a good chance of maximizing the longevity of our new designs. We need to be aware that if you put two metals together, two metals that are identical together, they naturally weld themselves more so than any other materials. So where you have metal on metal and any kind of load or pressure between the two, then they actually cold weld each other. So the asperities, the relatively rough areas of the surfaces, when they're in contact, actually stick together. And so because two materials of similar roughnesses will have similar asperity profiles, you get chemical interaction here and here, and these materials stick together. And if you're trying to slide this top material relative to the bottom material, you're going to get the creation of wear particles as one is displaced from the other. If we go to two different materials, so if we go to our example of polyethylene and metal, and we try and move our top surface relative to our bottom surface, if this is metal, this is polyethylene, then the far greater stiffness and hardness of the metal means it will just plow through the polyethylene. Meaning that area of material there would get dislodged from the polyethylene and end up floating around inside of our sealed synovial joint. So we have the risk of adhesive wear. We have the risk of deformative wear as well. where one surface effectively plows through the other. And whilst there's no problem plowing through it, it's the consequence of that plowing through that is the thing that we need to be concerned about, because it displaces material that is otherwise bound to the surface. And so these are the two principles that we're always conscious of when it comes to designing new implants. That we don't want similar materials because of adhesive wear and adhesive friction. We don't want materials of significantly different stiffnesses because of deformative wear and deformative friction. So how does this tie in together? So adhesive wear. So we generate wear particles. When the stuck surfaces separate as they slide past one another. But that may lead to the generation of abrasive wear, because these particles now confine themselves between the two surfaces as they slide past one another. So your clear, optimized lubricant, your synovial fluid, is suddenly contaminated by foreign body wear particles. And so your perfectly smooth engineered finishes are now sliding past one another in the presence of a grit within your synovial fluid. This cumulative effect can have and enhance the consequence of fatigue. And so this happens more and more. This is clearly a cyclical event. And you get erosion too, by virtue of the fact that you have an abrasive liquid constantly rubbing against surfaces. It doesn't have to be at the interface. It can be as, for example, the sea rubs against the land, then it rubs land away. There's no sliding as such past the land, or two surfaces sliding past the land. It's because this contaminated lubricant is in the presence of those perfectly smooth surfaces. We also have a risk of corrosive wear as well. Are we contaminating the synovial fluid to such an extent that it starts to corrode the surfaces? Of interest is that most of the mechanical concepts, these four here, are dependent on loading and distance traveled. And so we have this debate again. Are large heads versus our small heads? Our large head with a greater radius, greater diameter, means that you get an increased sliding speed. This is relatively small. And you get decreased contact load. So here the load is relatively small, here it's a lot bigger. Or the stress, I should say. But we have an issue here whereby the sliding distance is relatively small. The sliding distance here is a lot bigger because of those different radii. And that's a dilemma that we're faced with currently in terms of trying to identify the optimal design. And we can then try and work out the relative proportion of wear that you're likely to see in one material versus another. And perhaps an easy way of appreciating this is a stick of chalk. So back in the days where we had blackboards, the amount of writing you did with a stick of chalk and the amount of pressure that you applied to the blackboard when you were using it both influenced the amount of chalk that you used or the dust, the wear that you created. And so this is kind of what we're describing here. The volume of material removed, the contact force, and the distance slid are all important parameters in terms of looking at wear. And so we're after trying to control these as much as possible. We want to add a fluid. We know there is a fluid. But we want to use that synovial fluid within our design to minimize adhesive and abrasive wear as much as possible. And if we can do that successfully, we have the opportunity to dramatically reduce what happens in the joint and thereby extend the lifetime of the joint longer than what it is now. And we'll take a short break now because, yeah, I think fundamentally something has to change because we're looking now at marginal gains. There's nothing obvious that you can improve in a hip or a knee, really, in terms of the engineering designs of the components that currently exist. And yet, even here, we were talking last night of the increased risk of diabetes and obesity. Certainly that's probably more prevalent and more advanced a problem in the West than it is, I guess, in the East. And tied in with the fact that people are living longer. So you need these replacements earlier, and you want them to last longer as well. And neither of those are particularly healthy problems to have on their own. Combined together, then it kind of creates a perfect storm for orthopedic replacements because they're just not the advancement in technology coming through that you would expect to see. Still we're looking at polyethylene, and polyethylene was probably introduced maybe in the 70s perhaps, and we're looking at chemically superior versions now, but fundamentally it's still polyethylene. We're looking at metals now that may be subtly different alloys, but they're fundamentally still the same metals that are mixed together. The shapes and the radii are still pretty much the same. Maybe you can get a slightly smoother surface finish. But it seems that you're perhaps adding on years as opposed to decades in terms of the lifespan. That's not to say that there aren't lots and lots of people trying to find the solution, because there's a lot of value in finding it. But that's not to say that more people can't join the party and think of other ways of trying to achieve the same thing. So it's it's an interesting one, but quite where the answer is, or indeed if there is an answer. But it seems strange that the body can do it and make it look so easy, and yet we can't even understand what the body is doing to then try and replicate it. So there's clearly opportunity there, because it is possible to have a synovial joint that lasts longer than 20 years because we do it all the time. It's just a matter of trying to find those combination of engineering materials that will let it happen. Mm. Yeah, it's difficult. I mean, as we've discussed previously, it's all from a university perspective about getting research funding. And how can you convince anyone to give you money on an idea that's just an idea? And it's a matter of gradually developing that concept to get more and more data that demonstrates you have potential to outperformance there at the minute. And we'll come on to patient-specific implants later on. One would imagine that would have the opportunity to create the step change that we need, whereby you can design an implant that is the perfect size for the patient. That presumably has value, but the advantages of those haven't yet been systematically evaluated. The predominant patient-specific technologies is coming into the cutting guide as opposed to the implants themselves, and so there's more likelihood of you getting the off-the-shelf joint positioned in the perfect location, as opposed to the joint being size matched for the patient themselves. But there seems to be opportunity in there somewhere. It would seem naive to think not. But quite where that opportunity is not yet obvious. And so it's kept people busy for 50, 60, 70 years already, this problem, and it doesn't seem any more likely to start resolving itself. And it's ironic that, say, the natural joint lasts about 70 years, and we've been looking at this for about 70 years now, and the best that we can do is a fraction of what the body can. I think something in kind of tandem with tissue engineers is perhaps going to be where the solution lies, insofar as can we make articular cartilage and a scaffold for articular cartilage that effectively can enable your own cartilage to be taken out, regrown, and built around some kind of mechanical scaffold. Whether that will work or not, I think remains to be seen. Yeah, God knows how you would do it, but could you have some kind of polymer lattice structure that is 3D printed, that is matching the anatomy of the body, so that you could effectively have cells growing on that in the lab, and then you could pick that up and put it into the patient during an operation and let that tissue continue to grow. Sounds in some way doable, but you talk to the tissue engineers and they're struggling to make cartilage survive in the body at all. They can repair a focal defect, but there is no magic solution where you can inject a load of human cells into the joint and it will repair itself. And so the biochemistry and the tissue engineering environment that they're trying to operate in, and that they're trying to also achieve an identical solution of long-term synovial joint repair, they're not having any more success than we are. But you can't help but feel that a combined approach is in some way likely to be more successful than working independently. But again, that takes time and money. But that's research. And if we do solve that problem, then we'll want something else. We'll need it to last 60 years, not 40. So it's a matter of continuing to try and identify opportunities that appear to add value to a problem that's in demand. And hopefully, discussions from today may well be a part of that as well, fingers crossed. I think it goes back to the conversation again of yesterday, that until you know the biochemical profile of your patient, then it's very difficult to track why an implant was successful in someone and not in another. And I think it's, if we can have strain gauges that are wirelessly continually monitoring what's happening in implanted implants, then that kind of data will give us more benefit as well. And so I think it's, at the minute we see a snapshot of what happens at the time of implantation. We have clinical images that are recorded. We then have interim reports of the clinical outcomes from the patients, every couple of years when they go back into surgery, or probably when they go back to the surgeon complaining of pain. And then you have this final point when the replacement or when the replacement needs replacing. And so we don't have enough data that's describing success and failure. Yeah, I mean, if we could find a way of instrumenting what's happening, then we could track every success and every failure and start seeing whether there is a cause of premature failure in implants or a cause of failures at 10 years or 15 years, and whether there is anything that underpins those implants that are more successful. And so that's a big opportunity. If there's an opportunity, if there's a technical solution that is going to enable us to record data from implants via our mobiles, because everyone always has them in the pocket, the kind of the receiver is there. We just need the sensing and transmitting part of that system, because the receiver is presumably, in some way, the mobile is capable of collecting data from something. It's just a matter of building that interface so that you can continue to walk, continue to have strains and stresses measured in your knee, have that recorded, and then plot that against patient kind of perception or clinical pain. And to generate that body of data and to look at this hybrid field of engineering and tissue engineering are probably the two routes of progression that would be most advantageous at this stage. Alrighty, 5-minute break.